morning. Congrats, Dr. Vijay Kumar, and thank you also for inviting me. I think he has again shown his organizational caliber of collecting a lot of people. Very difficult to people for patient and for talks today. Okay. So my topic is going to be, I've been talking on primary prevention, and somehow you've already heard our studies on primary prevention. And I thought I put as primary prevention of diabetes, is it only a research and talks, or is it a practical reality? It's very important as physicians to know about what it's about. So if you have not been very familiar with the studies on primary prevention, what people have done is that taken people with high risk of diabetes, which is pre-diabetes, which is usually impaired glucose tolerance, and then try to do an intervention to see whether it can reduce the incidence or prevent diabetes or postpone diabetes. It can be done naturally by lifestyle modification, which Dr. Sabu was just talking about. And of course, you can also use pharmacological agents to reduce insulin resistance, or that can be done by using metformin. There have been studies with TZDs, and also there have been studies using insulin to see whether people with impaired glucose tolerance can be prevented from converting to diabetes. There has also been studies using obesity drugs, especially orlistat, to see those patients who are obese and who have impaired glucose tolerance, you can reduce incidence of diabetes. But mostly people have voted for lifestyle modification for being it's more acceptable and more cost effective and much more powerful to reduce insulin. There have been a number of studies. One of the first studies came from China, and that has been quoted the highest. And then came the Finnish diabetic study done by Jaakko Tuomelato, and then came the DPP from the United States, and of course the Japanese study. Now we have about actually 4 studies in India, the IDPP-1, IDPP-2, and then the Indian SMS study and the DECLIPSE study. I'll just share with you some of the points which may be useful for you. Now, what are the factors which determine the efficacy of an intervention? Now, you see a patient who has a slightly raised blood glucose and diagnosed with, you say it's a pre-diabetes, HbA1c is 6.2, you're not diagnosed diabetes, and post-glucose blood glucose is 160 milligrams, so you're not diagnosed diabetes. So you can try to see whether you do something to prevent diabetes. Now, in the studies that we have done, which the factors which determine the efficacy of the intervention are usually the level and the risk of diabetes in the subjects that you have in front of you. Now, we have been found that in India, the risk of diabetes among people with impaired glucose tolerance is much higher than the white population. And I'll give you a slide to show you that. Of course, the incidence rate of diabetes in the specific population, the number of subjects recruited will determine the statistical power. Of course, also the efficacy of the intervention used, the effective implementation. Now, you can tell somebody, okay, you start dieting from tomorrow, you start walking, and of course, you want to just a pill. The most important thing is whether there is usually an adherence to what you tell them. So, the effective implementation of the intervention strategy, namely, you can have sometimes dropouts and even what's called protocol deviation. Just to recapitulate, the first trial was called the IDPP-1, Indian Diabetes Prevention Program, and incidentally, this is one of the highest quoted papers on diabetes from India in the international literature. What we did was simple. Back in the 2005, we did started. People with impaired glucose tolerance are randomized into no intervention, lifestyle modification, and metformin plus both together, and we found that there was a statistically significant reduction in the incidence of diabetes in those people who were intervened, and that relative risk reduction was 28.5 with lifestyle modification, 26.4 with metformin, and a combination of metformin and lifestyle modification did not have an added benefit. But all the interventions worked and actually reduced the risk of diabetes in a time. The trial period is around 3 years, and we took about a year for recruiting patients. There have been subtle differences in the Indian prevention program with the Western programs. In most of the cases in the Western world, people are very obese. You can see the average BMI is 34 and 31 in the US and the Finnish trial, while it is only 25. So lean people develop diabetes, and the BMI is only 25 for the people with impaired glucose tolerance. So Making them lose a lot of weight was not a very good option, but however, we actually used lifestyle modification. What we found that with the average, there was no actually weight loss, even though we prevented diabetes. So this is one of the first papers to show that using lifestyle modification, even without a significant weight loss, you can actually prevent diabetes. The amount of metformin that used was very small, and compared to the US study, and there was moderate lifestyle modification. So it is a more a practical study, and that was now. We had lots of lessons from this study. One of the lessons was there is a rapid progression of pre-diabetes to diabetes. Now that is not published by me, but when we wrote that, this is published again by Juliana Chan from Hong Kong from our studies which we published earlier in Diabetology. I alluded to the fact that the conversion of pre-diabetes to diabetes is much more accelerated or much more rapid in the Indian population compared. And that is shown in this particular slide. And what is shown in the first one is the Finnish trial, where the cumulative incidence of diabetes was 23%, and the US DPP it was 11%, and the Japanese study it was 9%. That is the cumulative incidence of diabetes during the trial period, and the trial period is shown in the bottom, 3.2, 2.8, and 4 years. While in the Chinese, it was 68%, and the Indian it was 55%. That shows that if you are if you are diagnosing impaired glucose tolerance in an Indian, which we are all Indians, it's almost like diabetes because the incidence rate is 55% within 3 years' time. So your risk is pretty high, but the incidence is almost 70%. At this point, we wanted to see whether we can scale up the strategy. You know, by that time, we have all these studies come up. So primary prevention studies showed that it is possible to reduce the risk of diabetes in people who are pre-diabetes. But the implementation needed skilled personnel and a lot of money. It's not that easy to actually motivate people. So we want to see how do we scale up and reach large number of people, making it more cost effective. And that's the time the mobile phones became much more rampant, and the penetration of mobile phones was very high in the Indian population. So we use mobile technology to see whether we can actually motivate people to prevent diabetes. This is actually a study done along with the Imperial College in London. So what we did was to evaluate whether mobile phone messaging encouraging lifestyle changes could reduce the incidence of type 2 diabetes in Indian men with impaired glucose tolerance. We had only men in this particular study for some reason. So that is the design of the study. We had randomized them into 1:1 intervention group, which had standard care, and in the control group had the standard care. Well, when you have impaired glucose tolerance, it is mandatory. You have to tell the patients you have a high risk of diabetes, so you be on a diet, and if you are overweight, you reduce your weight, walk every day, etc., etc. Those patients in the intervention group had additionally messaging from the mobile phones from a server which we had. Of course, we had a software which was actually developed by the Intel group from the United States, which actually told us how to do that. So the computer decides according to the stages. Now, how do you know at what stage of change in their behavior they are, and what type of messages you should be sending them? So therefore, we used what is called the trans-theoretical model, where the behavioral change can be actually monitored. Every 6 months, the subjects were actually interviewed, and we actually categorized them according to this staging to see whether they have in what stage of change in behavior they are. And they are called pre-contemplation, contemplation, preparation, action, and maintenance. And of course, you have a relapse too, and so therefore, you may have to reinforce your motivational technique. So the messages that you send on the phone depends upon what stage of behavioral change they are actually situated, or they are actually measured. We used a little because some change of the messages could be used also by getting some feedback. So we used a feedback method in order to actually motivate those people. And surprisingly, we got a very good risk reduction. We got a very significant, this is called the Cox Cox-Proportional Hazard model, which is a survival curve, showing that there was a 36% reduction in the incidence of diabetes in those patients who received the SMS. So that's the conclusion, that receiving SMS regarding lifestyle modification among people with impaired glucose tolerance reduces the risk of diabetes in a 2-year period significantly. So that was the conclusion which was published in the Lancet. Now, at this point of time, there is a big explosion on the information. The Indian SMS study was the first clinical trial which used mobile technology. There have been other studies on tobacco cessation, on cancer treatment, etc. But this is one of the first studies in the world showing a clinical outcome using mobile phones. So that became very popular. There is another study published by Weber, which is again in the Indian population, done in Chennai, where again there is a relative risk reduction of 36%, but unfortunately they used metformin at an early stage, almost within 3 months. So therefore, this did not get a lot of attention because they did not wait too long with the lifestyle modification. But the aim of the study was to see that if you do not get success in lifestyle modification, you use a pharmacological agent within 3 months. Now, and I'm going to show you some of the analysis which we did. How did this strategy? Now, when somebody gets SMS and he's trying to change his lifestyle, does it work at all? It is damn sure that getting SMS does not change your metabolism. But getting SMS, if it changes your behavior, it will change your metabolism. So we've got to actually test whether it changed the behavior at all, and that has got any correlation with the incidence of diabetes. And of course, we also see whether early improvement can predict. And of course, there's a new thing called biomarkers. I'm sure when you are going to read journals and new textbooks, you're going to read more about biomarkers. Biomarkers is a new modern fashion to talk about. You have biomarkers for diseases like diabetes, cancer, and cardiovascular disease. In almost all the big trials, the FDA has made it mandatory that you have to keep samples for biomarkers. And I'll give you something about biomarkers in type 2 diabetes in the Indian population. Of course, the next question is, you did a study for 2 years. Does it have any effect afterwards? Because the life of an individual is pretty long. So therefore, has an intervention got any sustainability at all? First, by doing SMS, did it actually change their behavior? Now, Sabu was just talking about carbohydrate. Did it do anything good at all? So we did these measurements. And we scored the people according to the changes in behavior. And what is the score? First, if there's a reduction in carbohydrate, then that is number 1. Decrease in portion size of the total calories, that is number 2. Decrease in fat consumption, number 3. And of course, in the end, there was a decrease in the BMI at least by 1 unit, that is 4. And if maintenance of physical activity as per the advice given, that will be 5. So if you have all the 5 scores, then you will reduce the incidence drastically. But if your scores are less, then you fail. So what is the expected incidence? If you have a higher score, your incidence will be 0. But if you have low score, your incidence will be around 50%, is it not? Because the cumulative incidence was 55%. So that is the expected incidence if the scoring was correct. And what did we get? Exactly the same. So we found that actually, if somebody asked the question, oh, you did an SMS study, did the SMS change the behavior? And did the behavior reduce incidence of diabetes? Yes, it looks as if that the scoring showed that the behavioral change, which was actually motivated by the SMS, which was brought about by the SMS, actually has changed the risk of diabetes. The next question is, when you do a big study for 2 years, is there any way of seeing, well, when you see them after 6 months and after 1 year, are there any predictive value when you look at that? Now we did this. Now this is the graph again. At 6 months, there are some people who became diabetic. There are some people who became normal. Now is there a difference? And of course, many people continue to have impaired glucose tolerance itself. So therefore, the big question is there any difference in their risk later? So what we did was, we took up people, excluded the people who had diabetes, And then we had impaired glucose tolerance in 306 people, and then 130 became normal. So if you become normal within 6 months, then your risk of diabetes comes down. The risk is only 6.3%. That is the percentage you had. And while if you continue to have impaired glucose tolerance, then your incidence was 24%. In other words, if you look at this, there was a 75% relative risk reduction if you change somebody from impaired glucose tolerance to normal glucose tolerance within 6 months. So it's a very powerful tool. If you do not do that, then your risk increases. Therefore, it is worthwhile doing lifestyle modification and reversing impaired glucose tolerance to normal glucose tolerance, and that can be actually achieved within 6 months. A word about biomarkers. In all the big studies, cardiovascular studies, you would have read about this cardiovascular outcome studies, the MBARX, all of them are looking into what is called biomarkers. Now, what are biomarkers? I'll give you a definition on that. According to the NIH definition, it's a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological responses to therapeutic intervention. The FDA definition of biomarkers is any measurable diagnostic indicator that is used to assess the risk or presence of a disease. In fact, it's not only just like that. Actually, biomarkers are measurable biovariables. You can actually look at even an insulin value, or you can look at a C-peptide. You can even look at adipokines, interleukins. These are all part of what's called biomarkers, which are not only predictive or indicative of diseases, but also have a role in their pathogenesis. Therefore, looking at biomarkers, you can predict somebody is going to get a heart attack in 5 years' time. Somebody is going to get a diabetes in 5 years' time, and one person may get a cancer after some time. In that case, modifying them has a potential to change the course and onset of the disorder, such as diabetes and cancer. So you are going to hear more and more about biomarkers, and you will be seeing a patient in front of you, and if you want to prevent problems, you're going to order tests for like biomarkers, and that is going to come in future. And studies like the prevention studies only can give you the value of biomarkers. So what did we do? We looked at some adipokines like adiponectin, leptin, interleukin 6, and the HbA1c in the prediction of incident type 2 diabetes in the Indian population. And what did we find? We found that adiponectin was actually predictive. Low adiponectin, because increased adiponectin increases your insulin sensitivity. This is one of the first papers to show that low adiponectin is actually a biomarker for diabetes. The second one was interleukin 6. You can see the odds ratio was 2.27. You have a raised interleukin 6, your risk of diabetes is 2.2 times, 200 times higher. So therefore, biomarkers are coming into the textbooks, and very soon you will be asking for biomarker tests in your patients to see the risk of future disease, and changing them or actually treating them can actually reduce the risk of the disease which is going to come, and in this case, diabetes. So there's a mechanistic. Adiponectin improves peripheral insulin sensitivity, and interleukin 6 alters insulin signaling in the hepatocytes, adipocytes, and impaired energy regulation. So therefore, that is the role. So biomarkers can be easily measured, and they have a role in the pathogenesis, and they are modifying them can actually change the disease risk in future. Now, the next question is sustainability. I told you that when you do a trial and then leave them alone, it has got any post-trial effect. Now, if you look at the DPP, this is the cumulative incidence of diabetes in the DPP study for 15 years. The study was done only for 2.6 years, but even after 15 years, there was still what is called the post-trial effect. This is from the finished trial, a 13-year follow-up, which showed that there is a follow-up. Are there additional benefits? The only study which showed that there was very important cardiovascular benefits for the Chinese post-trial follow-up. You know, I told you that Chinese were one of the first primary prevention studies. So they had a 23-year follow-up on primary prevention. I hope you understand what I'm talking about. What I'm talking about, there's a 6-year diabetes prevention trial. In there they found diabetes could be prevented. And after that, the trial was stopped. Then they followed up these people for the next 23 years and see whether the first 6 years of intervention had any benefits for the next 23 years. Yes, it had a benefit. It not only reduced the incidence of diabetes by 45%, it reduced cardiovascular death by 41% and all-cause mortality by almost 40%. So that 6 years of intervention had a lifelong beneficial effect, not only reducing diabetes, but also having cardiovascular benefits. So I think catching people with pre-diabetes and instituting preventive measures is really worthwhile and actually improves your health. Well, did you have any effect in the Indian population? In the IDPP1, it is very difficult, it is very difficult. The most disciplined people in the world are the Chinese, and you can get them back. But the most undisciplined people in the world are probably Indians. We were not able to follow them up. But we did that in the Indian SMS study. In the SMS study, we had a follow-up for 5 years. And I'm going to give you the results. Not just published, it's under publication. And what we did was we actually got them back in the next 3 years and wanted to see whether there was a sustained effect of the prevention of diabetes. And what we did find? We did find there was a 30% reduction continued. So this was the first study from the South Asian population showing that there's a post-trial beneficial effect for diabetes prevention programs. And that shows you the statistics showing that both in the intervention and that there was a 30% reduction. The Indian SMS prevention trial started a new science in health, and that is called mobile technology, and this is called the mHealth program. After this, we had an international study on, again, mobile health in UK and India, and there's another big initiative by the WHO, what is called the mHealth, and also called M-Diabetes. They call it Be Healthy, Be Mobile, BHBM study, research leading into public health. This is the study which we are doing along with Cambridge and with Imperial College, where there are cohorts from India and also in England, where one of the difference here was we were recruiting people for the prevention study by only checking the HbA1c. We were not doing an oral glucose tolerance test, because doing an oral glucose tolerance test, spending 2 hours of time is very difficult, especially in the Western countries. So they wanted to do a one-time test of HbA1c. The study is just over in India and being just finished in England, and we will be getting the results very soon. A word about the WHO initiative. There's a committee called the M-Diabetes Executive Committee, and we are a part of that. In fact, it's a core components of this is Be Healthy, Be Mobile initiative is we have almost 10 countries which have done that. These are the toolkits, and there are the partners who are a part of this. There are companies as well as also telephone companies from different parts of the world. This is the WHO mHealth program, which is tobacco cessation, M-diabetes, M-cervical cancer, TB tobacco, M-hypertension, which is done in the United Kingdom, M-aging, and M-COPD and M-breathe freely. Now, in India, fortunately, I was a part of that. So the Ministry of Health called the WHO, and the WHO wanted us to be involved because we were the people who actually initiated this. So there's an M-diabetes program which just got implemented in India with the Ministry of Health. It was actually to test the feasibility of reaching and categorizing a large number of people using mobile technology, to enhance healthcare seeking behavior, to improve adherence to drug lifestyle changes and self-care, to assess the implementation and scope of scale-up of the program. So Government of India wants to say, oh, we are a digital world here like Aadhaar, and we want to use mobile technology in health in our country. We want to show other people that we are advanced. So what we did was, we did this methodology, and this whole algorithm was developed by us in Chennai. The registration, categorization, and then text messages were sent to people. And then the impact was done 3 months and 6 months later, and then they were all categorized. There was impact evaluation even after 1 year, and there were also stakeholders interview and the results. The program is over, we have the results, it's under publication. I just give you the first part of the results. Under the registration, Oh, of course, the ministry took all the credit for that. You can see it was actually launched in 2015. Government of India sent 130 million SMS in a week's time. Can you imagine the power of Government of India? That's fantastic. And they actually recruited 100,000 people. 1 lakh people responded within just one shot. And all of them got only one SMS. And so the response rate was not that bad. And then we had also website recording, and we had 64,000 on the missed call on the telephone and 43,000 on. This is from all over India, almost 10 states. And then we categorize them to diabetes and also pre-diabetes and of course gestational diabetes, etc., etc. And then we followed them up. So it's been a very effective program and just getting published in BMJ Innovations very soon. And now actually they called me and said they want to increase the program into crores of people, large numbers. In fact, there was more money allotted for this, and probably this is going to be not only an SMS, but they are going to use IVRS. So we are actually working on the algorithm how to recruit a large number of people. And I found that even some people in Chennai got the messages and were actually a part of this. And mostly those people from Punjab, Maharashtra, Northeast, Bihar, Uttar Pradesh, Madhya Pradesh, etc. So I'm not going to. So to conclude, India has large population of diabetes and pre-diabetes, and is expected to further increase in future. We have new data on epidemiology, which is just finished, and it's really pretty high prevalence rates that we are seeing both in urban and rural population. The conversion rate of pre-diabetes to diabetes is faster among Indians. High prevalence of pre-diabetes gives us a target population for possible prevention programs. Therefore, primary prevention is an option, and our studies have shown the usefulness of scalable strategies for primary prevention. The Indian SMS prevention study has encouraged many M-Health initiatives. M-Diabetes program started by the WHO has been now tested at national level in many countries, including India. I want to acknowledge my thanks to my collaborators, my research group. Thank you.